Michael Myers. I am the Chief Communications Officer for the Diabetes Research Institute Foundation, and it is really my privilege and honor to welcome you this evening. These webinars, our Meet Our DRI Scientist webinars, are an opportunity for our scientists and our community to really engage with each other, to get a better understanding and appreciation for the amazing work that's happening at the Diabetes Research Institute on a daily basis, and how that work is helping move and progress our efforts toward our mission. Before we get started officially, I wanted to just throw in a couple of housekeeping items. This call is being recorded, as you heard. We will have the recording up on our website at diabetesresearch.org by early next week at the latest. I'm also going to ask that any questions you have, you please submit them via our chat line, and please include your first and last name. In the event we don't get to address your questions during this call, I want to make sure that we have the opportunity to follow up with you individually, at which time our scientists will be able to respond to your questions. So without further ado, these webinars create a great opportunity, as I said, for us to engage with the communities that we serve. And I thank you for being with us tonight. Every day, our scientists, clinicians, and collaborators work at the forefront of diabetes research, developing transformative strategies to restore natural insulin production, modulate the immune system for greater tolerance, and advance regenerative and stem cell-based therapies. From early discovery to clinical trials, each investigation moves us closer to turning scientific innovation into real hope for people and their families living with diabetes. And each represents a key step forward toward our shared goal, a world without diabetes. It is my privilege to welcome our two scientists tonight who will lead the discussion on our topic, which is advancing diabetes treatment, technology, trials, and the future of beta cell preservation. Dr. David Bidal is an assistant professor of medicine and clinical investigator at the University of Miami Diabetes Research Institute. Dr. Bidal is a physician scientist who specializes in type 1 diabetes, advanced diabetes technology, and beta cell replacement therapies. With training from the DRI and Harvard, he leads several clinical trials focused on preserving and restoring insulin production, including prevention studies and innovative islet transplant approaches. Dr. Bidal also cares for patients with type 1 and type 2 diabetes, bringing research discoveries directly into clinical practice. Dr. Carlos Blaschke. Dr. Blaschke is the Director of Clinical Research and a research assistant professor at the Diabetes Research Institute. His work centers on large, collaborative clinical trials aimed at preventing type 1 diabetes and protecting beta cell function. He played key roles in landmark studies such as the TrialNet teplizumab trial, which led to the first FDA-approved therapy that delays type 1 diabetes. Dr. Blaschke also leads community education and early screening efforts and is committed to mentoring the next generation of clinical researchers. Our presentation by our two scientists will be approximately 45 minutes, after which we will introduce a Q&A segment. If you have any questions, please again submit them via our chat line with your full name, and we will address as many as we can during the call. And those that we don't get to, we will respond to directly, individually after the call. Without further ado, I would like to turn it over to David and Carlos, our scientists. Gentlemen, the floor is yours.
Thank you very much, Michael. I'm starting to share my screen. Thank you again for the very kind introduction. And basically what we will do today is we'll start providing, and I think it's just appropriate as an institute specialized in diabetes and focus in type 1 diabetes, it's important for the audience to know what are the current technologies that we have available and the expertise that we have with the utilization of these technologies before we dive into the clinical research opportunities that we have and how that is really shaping the lives of our patients with type 1 diabetes, giving them hope for interventions that can actually preserve insulin production and improve their glucose control and their lives with type 1 diabetes. So let's get started. So I think it's very important to highlight one of the technologies that has really revolutionized the management of type 1 diabetes, and those are the automated insulin delivery systems. And what do they comprise? An automated insulin delivery system comprises a pump, which can be a tether pump, as you can see here, or a patch pump, a continuous glucose monitor, and an algorithm that dictates insulin delivery, which can be housed in a smartphone, it can be housed in the pump itself, or it can be housed in a device that is called a dedicated device for the algorithm. And instead of just having the data limited to the patient, this information now flows through cloud servers, allowing for data analytics. All this information can then be clustered together, analyzed together with the specialist in clinic visits, allowing for detailed information and accurate fine-tuning of diabetes control. But the most innovative issue is the fact that the AID system, again, comprising the pump and the CGM, has an algorithm that is fed by the data from this continuous glucose monitor. And the feeding of this algorithm with this data allows for the automation of insulin delivery, making these changes and these decisions in insulin delivery without the patient having to provide significant input. There's still input that is required, particularly for meals and for corrections, but the basal, the amount of insulin in the background, is controlled in large by this automated algorithm. And what we have learned from the use of these technologies, and this is just data from one particular algorithm, the Control IQ, and to illustrate and to better understand for the audience, I think most of our type 1 diabetes patients will be familiar with the use of CGMs and the time in target range, which is the recommended is when you look at CGM data, is this range of sugars between 70 and 180. And current recommendations are for patients to be more than 70% of their time within that range of 70 to 180. And what this graph is trying to depict is that independent of how much time you're spending in range, whether it's a little bit of time, whether you're already above the 70% threshold, being on these systems increases further your time in range. Clearly, if you start out low, the increment is much higher. But even if you are doing extremely well with a time in range of 80%, your time in range can further improve on these systems. And what we have learned is that on average, these automated insulin delivery systems can increase your time in range between 10 and 26%. They can decrease your hemoglobin A1C, minimize the occurrence of hypoglycemia, low blood sugars, and they can increase treatment satisfaction, improve sleep, and decrease diabetes stress. So all of these benefits can be obtained with these technologies. And patients have different options now. There are actually, as you can see here, 5 automated insulin delivery systems that are FDA approved and commercially available. And we're going to discuss very briefly a little bit about them. So let's start with the MiniMed 780G system from Medtronic, which has this smart guard technology, which allows for these small autocorrections that are occurring in the background. Again, all these systems will modulate basal insulin delivery, and there are some differences in how they manage the sugars rising or what happens when your sugar is high after a meal or during a meal. This particular system has a technology known as meal detection that I will show you in a little bit, in which based on the rise in the blood sugar, it can detect that a meal has actually occurred and then enhances the amount of insulin that is delivered to minimize staying in a high blood sugar for too long. In addition, you can actually set 3 different blood glucose targets by increments of 10. You can keep the blood sugar target at 100, 110, or 120, and this can be adjusted throughout the day, accounting for different scenarios. For instance, you may want to have a very tight glucose control overnight and keep it at 100, or you may want to have it a little bit less tight during the day if you're a little bit more active to avoid the possibility of low blood sugars. And further, if you're going to exercise, there's an option here that you can set a temporary target to 150. You cannot change this target. That's the target is 150. And you can keep this target from 30 minutes to 24 hours. And when you do this temporary target, it will disable these little auto corrections. And it makes sense because the only reason why you're raising your target is because you are concerned that activity that you may be engaged on may be dropping your blood sugars. And you don't want the system to give you an automatic correction if you're more insulin sensitive, if you're more active, and if you're more prone to have hypoglycemia. And this system requires that certain parameters are met to remain in automation. If those parameters are not met, the system will get you off automation, but it will give you a warning or a signal, an alarm telling you what needs to be done to return to automation. But patients can rest assured that if they come out of automations, you go into this safe basal. It's a period of time in which the system is still modulating your basal insulin based on what it has learned from before. It's just that at this point, it's not that algorithm is not being fed because something happened and you lost the automation, but you still go into this safe basal, which for up to 4 hours. So if the user does not fix the problem, which there will be an alert to tell you what you need to do, it will then default to manual mode. And manual mode essentially is the program basals that you have entered into the pump system. What are some of the limitations is that there are no extended boluses. A lot of the patients probably struggle and they know the frustration with having a high fat, high protein meal leading to rises in the blood sugar 3 to 4, 5 hours later, and the benefits of having an extended bolus that can be done in a manual mode pump setting. But once you're in automation, the system does not allow you to extend the bolus. In addition, you cannot have defined temporary basals. For instance, you're going to go for a run and you're running for an hour at high intensity and you would like to decrease your basal by 50%, just to give an example. That unfortunately cannot be done when you're in automation. And the system doesn't have a sleep mode feature to enhance tighter glucose control overnight, although you can decrease your target to 100. This is a little schematic showing you how the system works. You have here on this area, the blood sugars, and this gray line here shows you the trend of the blood sugar. And what happens here, and you can see these little lines over time, this is the insulin being delivered every 5 minutes by the pump. And based on the sugar profile, you can see the increments in the bars. And if the sugar is actually getting to be above target and quite high, you actually get these little automatic corrections every 5 minutes to try to minimize the hyperglycemia and bring you down. And then if you're predicted based on the algorithm to be low, what will happen, or if the sugar is dropping below a defined target, the system will start giving you less, and it will even stop giving you insulin until the sugar stabilizes and then insulin delivery resumes. And this is the example of the meal detection. So the typical curve here, as you can see after you eat, can have two pathways here, two options. If the system meal detection is engaged, what happens is that you get a stronger correction to try to mitigate or minimize that hyperglycemia that is going to occur after you eat. So instead of having this profile, what will happen is you will have a lower exposure in high blood glucose because the system is giving you more insulin to try to compensate. Perhaps you didn't give enough insulin upfront to cover the meal. So you get a stronger correction to minimize the hyperglycemia. Now shifting to the tandem pumps, where you have the X2 pump that has a touch screen and everything can be controlled directly from the pump, or the Mobi pump that does not have a touch screen and is completely controlled via an app on a phone or a smartphone. And they use their algorithm known as Control IQ. And these are some of the unique features of the Control IQ algorithm. Once you're in automation in the system, the glucose target by default is set to 112.5 to 160 milligrams per deciliter. That's what the system will try to keep you on. That's your default target. And if your blood sugar is predicted to be more than 160, your basal will start to increase. You will get a little bit more basal to try to bring that blood sugar down. And this system has these auto corrections. When your blood sugar is predicted to be more than 180, you actually get 60% of a full correction. Imagine that if you're not in automation, if you're just on a pump, and let's give you an example, your correction factor is 1 unit per every 40 points, and your target is 120, and your blood sugar is 160, therefore you need 1 unit of correction. The system will actually give you that correction based on where the sugar is, and it's predicted to be more than 180, but it will only give you 60% of that correction. It's a safety feature. It doesn't give you the full correction, because remember, the system is also going to adjust the basal and hoping that the patient may also ultimately intervene. But it does give you a correction to try to mitigate and minimize the exposure to the high blood sugar. And then if on the other hand, your blood sugar is predicted to be below the target that you're supposed to be in, your basal starts to decrease. And if you're less than 70, or you're predicted to be less than 70, your basal insulin delivery will stop until the conditions improve, the sugar starts rising, and everything resumes. It does have an exercise mode feature where the target is raised to be within 140 and 160. It also has a sleep mode feature where the target is set to be 112.5 to 120, keeping you much more tight control overnight. And it stops the autocorrections. As again, as a safety feature, it wants to avoid giving you a correction overnight while you're sleeping because of the risk of potential hypoglycemia in that scenario. And one of the unique features is that while in automation, you can actually extend the bolus up to 8 hours, and patients with type 1 diabetes can realize the benefit of having such a feature where, particularly for those high-fat, high-protein meals, you can extend the bolus to avoid and minimize that rise that occurs quite late after those meals. And you can also set temporary basal rates while in automation. Some of the limitations, unfortunately, of the system is that you do not have customizable targets. What does that mean? For instance, let's say that I will want to have the system to have a target blood sugar of 120 to 130 from 3 to 5 p.m. because of a certain activity that I'm going to do. Unfortunately, I cannot do that with this system. And this is just a schematic of a particular patient looking at 2 days of data on how the system works. Here you see the blood sugar trends within that 70 to 180 range. And the basal in the background is shown here as it starts to accommodate based on the blood sugar. It goes up and down. And then you see this here. This actually, with this little diamond, depicts an automatic correction because the sugar is going up, it's predicted to be more than 180, and the system engages and gives you a correction to try to bring the blood sugars down. Now switching gear to the Omnipod 5 system, and one of the advantages of this particular system is that it's the only currently available patch pump in the market. And it is very popular among kids and also among young females because it's very discreet. You can conceal it better than having a tether pump with an infusion set. And it uses this adaptive basal technology. It provides an adaptive basal rate. It calculates the total daily insulin dose. You initially have to enter and program your basal rates in this manual mode, but then it learns from that. And with every time that you change this little device here that is called the pod, that houses all the, it's essentially the hardware of the pump and is replaced every 3 days. Every time you replace it, the algorithm gets updated and learns from how much insulin you've been using over the past 24 hours and readjusts your basal. And you can actually set customizable targets at 10-point increments from 110 up to 150. And it also has an exercise mode feature. However, one of the limitations is that it does not have auto corrections. Although the basal does increase and gives you a little bit of increments to bring the blood sugar down, it doesn't give you a correction per se. And it doesn't give you the flexibility of an extended bolus in automation. You will have to stop automation, go to manual mode to give an extended bolus. And again, there are no temporary basal rates that you can set while being in automation. And again, there is a little bit of a schematic of how it works. Well, as the sugar is in range, you get your insulin delivery in the background. If it starts going up, it starts giving you this tiny little correction, but it's not a full correction. But it tries to correct and bring the blood sugar down into the target range. And then, of course, if the blood sugar is predicted to be low, it will stop giving you insulin as other systems do, and then it restarts once you're back in a safe range. And now we move to the iLet from Beta Bionics, also named the artificial pancreas. And what is unique about this feature is that to enter in automation, you only need the patient's weight. It decreases a lot of burden from patients from the perspective that you don't need carb ratios, you don't need any correction factors for this system, you don't need to do any carb counting or set any basal rates. What you do need to is to announce for the meals, is this meal announcement. You need to let the system know that you're going to eat, whether you're going to have breakfast, lunch, or dinner. And it uses this qualitative meal estimation based on the algorithm that is housed in the system. You need to let the system know whether that meal that you're having is your usual meal, is it lower than your usual, or higher than your usual. And that's all you need to input for the system to provide you an insulin dose and it has this artificial intelligence, and it will start learning and relearning and readjusting based on the response. The only thing that you can actually set in the system in this particular algorithm is your glucose targets, which can either be the usual, which is set at 120, lower than the usual, which is 110, and higher, 130. But that's the only setting that you as a user can modify. The rest you cannot modify, but you need to announce for the meals. So you can see the appeal of this system to somebody that doesn't want to have to worry about too many things. Just announce the carbs. The system will take care of the rest. What are the limitations? Unfortunately, these targets that you can accommodate for, you can only do them over a 2-time period in 24 hours. So what people may tend to do is they may have the lower target overnight to keep the sugars in range overnight and much more strict control. And then you may need to use during the daytime a usual target, or if you're having drops in your blood sugar during the daytime, you may need to adjust that to higher than usual. There are no auto corrections. You do get those tiny increments in your basal. There are, yes, small corrections that occur, but it doesn't give you a full correction if the sugar is high. It tries to fix it by improving the delivery every 5 minutes of your basal. And also, you cannot do extended boluses if you're having a high-fat meal. The system tries to compensate by giving you, again, those little corrections with raising a little bit of the amount of insulin every 5 minutes. And there's no manual mode settings. You can imagine there may be scenarios, for instance, if you're acutely ill or if you need steroids for whatever reason, where your sugars are going to go up dramatically, and the system may not be able to learn and accommodate quickly enough to compensate for this high insulin resistance. A scenario where if you were able to go into manual mode, you could change the settings to make it more aggressive and minimize the high blood sugars. Unfortunately, the system does not have the luxury of entering any manual mode settings. And there is a little bit of a perspective of how, and a schematic of how this works. You have the glucose target, the sugars here, and the different algorithms, how they play in here. You have the basal in the background changing, depending on the blood sugar. If it's going a little bit too high, you're gonna get these little corrections here depicted in purple. And here are the meal announcements to avoid high blood sugars. And if you're underdosed, the system will give you these little corrections to try to bring the blood sugar down. And now the new kid on the block is the twist pump system. And the twist is unique in that it's the only system that has the lower target range and the highest target range in the market. You can go down as low as 87 milligrams per deciliter and as high as 180 milligrams per deciliter. In addition, it uses this sound wave technology that is able to quantify much better because of the sounds and the clicks, the amount of volume that is delivered with each dose, allowing for more precise microdosing of insulin delivery. And one unique issue is that as differs to other systems where you only enter the carbs and then you get a dose based on the amount of carbs, this takes into account the absorption of those carbs, which is a unique addition into the algorithms of insulin delivery. Now you can let the system know that you had a carb that is typically absorbed very fast, white rice, a candy, an ice cream, or something that is that is absorbed very slowly, such as a pizza, for instance. And you can tell the system, sorry, I think I heard something in the background, but then you can tell the system, I'm having this amount of carbs, but these are carbs that are slowly absorbed, or these are carbs that are fast absorbed, and the system will take that into account when it delivers the insulin. And more interesting, and also unique to this system, just to give an example, let's say that you actually put in that you were having something that is slow absorbed, and you entered it, but then you realized that, you know what, I actually ate something that is medium or fast absorbed. You can go back and actually enter in the algorithm that you actually had different amount of carbs. You can actually change the number of carbs that you gave, you didn't eat them all, and you can change the velocity of the absorption. And that will adjust, the system will adjust to that information in regards to the insulin delivery. Although it doesn't give you an automatic correction, it does what other systems also do to some extent. This will calculate if you need a correction, what is the amount of that correction that you need? And over a 30-minute period of time, will space it out and deliver it with little increments in your basal. And you can also set temporary correction ranges you can have pre-meal presets that you let the system know that before meals, it should target blood sugars that are a little bit lower so that the system is already, before you're going to eat, trying to keep your sugars in a better range so that before you eat, you start with better blood sugars. Or you may want to have your sugars a little bit higher before exercise, and you can do this workout preset so that the sugar is a little bit higher or at a range that you feel comfortable before you go into exercising. But again, one of the limitations is that does not give you an automatic correction bolus per se, but it does spread a correction over 30 minutes by increasing your automatic basal. And it has this 6-hour horizon window of prediction. So in this figure here, you have a glucose target of 100 to 120. You have the blood sugar in the background. And here what can happen is different options. When you see the star, if your blood sugar is predicted in the algorithm that over the next 6 hours, you're actually going to drop, the system will stop giving you insulin. If it's predicted that you're going to drop, not going to be hypoglycemic, but you're still dropping below what your target is, it will give you less basal. And if you're predicted to actually stay in range in the next 6 hours, it will let it go as it is. And if you're predicted to be high, the basal will actually increase. And then it readjusts. But you have this 6-hour prediction horizon for the system to work with and adjust your insulin. So with that being said, I'm going to shift gears now and have Dr. Blaskett take over information regarding some of the therapy milestones that we have had through the years in type 1 diabetes. Dr. Blaskett, please.
Sorry, I was unmuting myself. So good evening, everybody. I'm going to take you back now a little bit back in history. Dr. Vidal just walk you through of amazing technologies available for people with diabetes. So I'm going to take you back to 1922 when the first human, actually a 14-year-old boy with type 1 diabetes was treated with the first human injection of insulin. If you see since 1922 to the beginning of the 90s, everything was to actually develop better insulin, develop better technology left to measure the blood glucose. But then in 1993, the first trial that actually was a landmark trial in diabetes called the DCCT, the Diabetes Control and Complications Trial, that it was published in 1993, followed about 1,400 people for almost 7 years. And they compare people with intensive therapy versus conventional therapy. Intensive therapy means multiple injection, and not that frequent blood glucose checks. And conventional will be like 1 to 2 injections with less frequent glucose checks. So the DPT, actually, the DCCT shows that if you have better control of your insulin, you really decrease your complications in the future. So better control, less complications in the future. And that's one of the landmarks that changed the way we treat type 1 diabetes at this moment. So at that moment, one of our chief academic officer and one of our mentors, Dr. Skyler, put together this network called the Diabetes Prevention Trial at the beginning of the 90s. So he put together the group doing research in Europe and the group doing research in the United States. And then there was the first actually studies to try to prevent or preserve beta cell in type 1 diabetes. Then this DPT-1 evolved for TrialNet that started at the beginning of 2001. And then that led for many, many trials that I'm going to walk you through now for the first approval therapy in stage 2 diabetes. Next slide. I'm going to walk you through about the natural history of type 1 diabetes so we understand why we're doing these trials and when do we do these trials. So we know that if you have a family member of people with type 1 diabetes, you have a higher chance to develop type 1 diabetes. So you have to have a genetic risk. So when that happens, something in the environment triggers your immune system, and that becomes your immune system becomes activated, and then it becomes activated and start attacking the beta cells. Then there is become the immune response, and then we can measure in blood the first autoantibody. Then it actually starts the stages as the American Diabetes Association has classified type 1 diabetes as a stage 1, stage 2, stage 3, and stage 4. Stage 1 is when you have normal glucose, but you have 2 or more autoantibodies, and we can check that in an easy blood test. Stage 2, that's when you have 2 or more antibodies, but you already have some abnormalities. So if we check, it's not actually a clinical diagnosis of diabetes, but you have some impaired glucose already. So your glucose, your sugar is not in the normal ranges. And then stage 3 is the clinical diagnosis. Actually, the majority of kids and people with type 1 diabetes get diagnosed in the hospital. Some people get diagnosed with diabetes ketoacidosis, some by the doctor just with a random blood glucose. And then stage 4 is when the people have long-standing diabetes already, many years after the role. And so if you look at this cartoon, we can see in different time points of the natural history of the disease, we can screen, and with that we have several ways to screen people, and one of the big networks that we use with Dr. Vidal who is the principal investigator for that network, is the TrialNet network, and we do the natural history trial when we screen family members of people with type 1 diabetes for autoantibodies, and we can screen and predict who is in higher chance to develop type 1 diabetes. We can also do studies to try to prevent or stop the progression between stages of type 1 diabetes, or we can do studies to preserve the beta cells in stage 3 when somebody is newly diagnosed. Or we can replace, and Dr. Vidal and Dr. Ricordi and Dr. Alejandro, they're big in the islet cell transplantation and stem cells. Our talk today is going to be more in the preservation of beta cell, so in stage 3 diabetes. Next slide. So I want you to see this slide, and in the y-axis, you're going to see more or less in most of the slides the C-peptide. In this case, it's the event probability for diabetes, and in the x-axis, you're going to see time. It could be weeks, months, or years. In this study, it was called the TN10. It's a TrialNet study that it was done in stage 2. So remember stage 2 when I said 2 positive antibodies and impaired glucose. So no clinical diagnosis, but it's more or less like a pre-diabetes before the clinical diagnosis. So these people already have a normality. This study was, the purpose of this study was to try to delay the transition to stage 3. And then we did is a 14-day course of teplizumab. That is a monoclonal antibody that targets the T cells. And we did in the high risk of people or relative of people coming from the TN01 trial that did the screenings for autoantibodies. If you look at the trial right here, I don't know, David, if you can press so we can see the people that received teplizumab actually got a benefit. It's a 2-year delay versus the people that got placebo. 76 participants were enrolled, and once some of the people went to the teplizumab arm and the other one to the placebo arm. So the median time for diagnosis was in teplizumab was 48 months versus placebo, so 2 years delay in type 1 diabetes, therefore significantly lower annual progression rate in the teplizumab group. Next slide. So if you look at the extension that we do, the extended follow-up, also it actually longer that we can delay the onset of stage 3 diabetes. You see 32 months if you look at the teplizumab. It starts decreasing, but it still has some benefit. And you look the percentage of the people with new onset was 50% in the teplizumab arm, and 78% got diabetes in the placebo arm. So next slide. So we're going to talk about some effects, and this is in stage 2. So people didn't have diabetes. So now we're going to move a little bit to the newly diagnosed area. So these are people effective therapies that we have done with different groups at the Diabetes Research Institute. Next slide. So if you look what I said in the past, this in the y-axis, the C-peptide, and a C-peptide is like a short protein that is released when the pancreas produces insulin. So it's extremely useful, this C-peptide measurement, to see how much insulin your body is making. So if you look in this trial right here, it was called the anti-CD20 trial, or the rituximab in new onset trial. So we did people between the ages of 8 to 45 years old, newly diagnosed, and we did infusions of anti-CD20, and some people got placebo. And if you look at the C-peptide, look at the year, the first year, there was a big difference between the people getting rituximab and the people getting placebo. But after the 12 months, the lines start getting very, very overlapping. So the effect was lost. Next slide. So this is another study that was done in TrialNet. This study was called the ATG-GCSF in new onset type 1 or TN19. And if you look, we did 2 infusions of ATG in people with newly diagnosed within 100 days after diagnosis. We didn't put the ATG-GCSF because it didn't have any impact, but the people that got ATG, actually, the group alone has significantly, you see the preservation of C-peptide after 24 months. So it shows a very good effect. So next slide. So this is another study that we did, that we didn't do, but we're going to start doing while the Diabetes Research Institute. Is called the golimumab study. It's an anti-tumor necrosis factor blocker. And in this study, if you look at the y-axis, also we look at the C-peptide. This study was done in people between the 6 to 21 years old, newly diagnosed, again, within 100 days. And people were getting the subcutaneous injections for 52 weeks. Then 52 weeks of the therapy, you see the golimumab really preserved the C-peptide again versus placebo. So it looks very effective after 52 weeks of treatment. After 1 year of therapy, the golimumab group had much less decline C-peptide. In the year that we did a follow-up, the C-peptide continued to preserve, but it really declined a little bit. Okay, next slide. So this is another study because of teplizumab. It was because of the TNT was approved in 2022 in stage 2. We did a study at the Diabetes Research Institute looking at also with teplizumab. Actually, we did 2 courses of teplizumab, 14 days infusion. Oh, I'm sorry, it was 12 days, right, David? 12 days infusion in 6 months apart. And then we got also newly diagnosed people actually in the first 6 weeks. It was actually shorter the period to enroll people. And if you look also, the teplizumab group really preserved the C-peptide. So that means that your body was still making their own insulin. So the primary endpoint was met. This study actually was published, and the company that owns the rights for teplizumab is looking for approval at the end of this year, beginning of next year. So it's probably going to be approved in stage 3. We'll stay tuned for that. So next slide. So this is another study, very interesting study. This is it's called actually the Bandit study. It's baricitinib. It's a JAK inhibitor. It's one of the new drugs that is used in other autoimmune processes. Actually, in this group was age 10 to 30 years old, newly diagnosed. Also, within the 100 days, they took this pill on daily basis for 8 weeks, follow up for 48 weeks of observation after stopping the drug. So that means 1 year taking the drug, 1 year off. So 48 weeks taking the drug, 48 weeks off the drug. So the baricitinib treatment led better preservation of C-peptide compared to the placebo. So meaning more preserved insulin production. So but we stopped it after that. We stopped the drug. But the therapeutic benefit diminished actually in the baricitinib group. So that means that probably we kept these people in the drug, probably the benefit will see that benefit longer. So next slide. And this is another study. It's called the verapamil. The verapamil is a drug that has been in the market for many, many years. This was done in pediatric type 1, newly diagnosed type 1 diabetics. The verapamil is a calcium channel blocker commonly used in hypertension and some heart conditions. But it shows, so in the beta cells, it shows that reduce something called the TXNIP. And this TXNIP is like something that, put in this way, it will kill the beta cells. It's like an apoptotic factor. So reducing this TXNIP, it will preserve the beta cells. That's the hypothesis in this trial. So in this trial, it also was a newly diagnosed. Actually, it was shorter. It wasn't within 31 days after diagnosis, and age was 7 to 17 years old, 62 weeks, 1 year of verapamil or placebo, and you see the verapamil really preserved the C-peptide better than placebo in 52 weeks. I want to say that there is one study that was just published, actually presented last month in the European meeting, but it was in adults. It was 18 to 45 years old, and they also was newly diagnosed in the first 6 weeks after diagnosis, and the primary endpoint was to see also beta cell preservation, looking at C-peptide. In that study, unfortunately, they didn't met the primary endpoint. So stay tuned for that. There's some groups that are looking at, they're saying that probably the placebo arm was underpowered, but in the adult cohort didn't show any benefits, so that we couldn't reproduce this what we saw in the pediatric group. Okay, next slide. So I'm gonna jump into the stage 3 clinical trials that we're doing at the DRI. Next slide, please. We are doing right now is closed for enrollment because we did really good enrolling people. This is called the JAK inhibitor in type 1 diabetes, or the JAK-POC type 1D. It's actually multi-center, is under the TrialNet network, and we're one of the clinical centers. It's a randomized double-blind placebo-controlled study, and what we did is also putting people starting at the age of 8 within the 100 days of diagnosis. And if you look here, so we put 3 groups. One group, it will get one of the JAK inhibitors called abrutinib. Another group will get rituximab. This is another JAK inhibitor, and another group of placebo. So this is for 1 year. All these kids are taking a pill on daily basis, and we're looking to see if we can preserve C-peptide at the end of the study. This is ongoing. It's not recruiting, but we're doing it's in active follow-up. Next slide. So we're doing actually another study because of the studies that I showed before, the rituximab, that we showed some benefit at 12 months, but that was in the newly diagnosed area too. So in this one is actually, next slide, is the first study that that everybody gets rituximab, anti-CD20. It's another monoclonal antibody that targets the B lymphocytes, depletes actually the B lymphocytes. So everybody gets 4 infusions. There is no placebo arm at that point of the study. It's in newly diagnosed. We are not recruiting because it's closed. We recruit very well, and we have patients in active follow-up. And then after finishing, there is a 3-month lapse after the infusion is done, and then they start with subcutaneous abatacept weekly for weekly injections for another almost 2 years of follow-up. Yeah, for 20 months and 2 years of follow-up. And we bring these people to see measure something called the mixed meal tolerance test, just to see if we can see any changes in the C-peptide. Next slide. And this is a study that Dr. Vidal is going to talk about. It's with in the newly diagnosed. Actually, I think it's within a little bit longer. Most of the study that I present, it was in the first 100 days. This is actually a study that is within 1 year of diagnosis.
Thank you, Dr. Blasio. So we're now shifting gears because the previous studies were done under the TrialNet network, but we also have other studies that we work with pharma that we feel are have a clinically sound to be done, and where we feel that the science is strong, and we want to pursue those studies. This is called CREATE-1, and it's testing cell C, and it's based on the use of stem cells. These are perinatal derived tissue. These are umbilical cord derived stem cells that are expanded from a single donor. And the audience will probably know that there's a lot of literature and information about the anti-inflammatory benefits of stem cells and the potential role in immune modulation, how they may affect in a favorable way the immune system. And the idea of this particular trial is to actually provide with adult patients that have 1 year of diagnosis an infusion of this perinatal tissue-derived cells. These are umbilical cord derived and from a single donor, and to take advantage of reducing inflammation and also favorably changing the immune system. And what is unique about this trial is that other studies have used mesenchymal stem cells or there are different types of stem cells intravenously. But this trial is trying to deliver the cells to the site where the problem is occurring, that is to the pancreas. And the way to do that is that it's being administered through an artery. They go through the groin and they advance a catheter close to a vessel, one of the arteries that feeds the pancreas. And that is where the cells are delivered, with the hope that by delivering them directly at the area that is had, where all the disease is happening, you can decrease the inflammation and have a favorable immune response, hopefully reducing the loss of insulin-producing cells. And although here it says it's 180 days, this actually protocol has recently been modified, and it's up to 12 months. So it's also unique in that you have this large window of time where you could benefit from participation into these studies. But because it requires a procedure that goes through the artery, it is limited to adult patients, not to kids. And then shifting gears from stem cells to antigen therapies, we have this study, the DINO3 study. And an antigen is a substance that triggers an immune response. And the patients and our audience with type 1 diabetes are probably quite familiar with the GAT65 antibodies, the IA2 antibodies, insulin antibodies, zinc T8 antibodies. All of those are antigens that elicit an immune response and allow for the activation of the immune system and ultimately the development of type 1 diabetes. That's what we can monitor in the blood in the form of antibodies to check for immune activation. But there's a lot of interest in trying to re-educate the immune system. So if we have a way to provide the system with that same antigen, but re-educate the immune system in such a way that now it doesn't recognize that antigen as something foreign that it needs to attack, but rather as being self, the immune system and the immune attack may dampen, and therefore you can preserve insulin-producing cells. And that's the rationale of antigen therapy in type 1 diabetes. And this protocol is novel in that it provides and delivers this antigen directly into the lymph nodes, which are these clusters, these little lymphoid organs, these organs that are throughout your body and in these chains that where immune cells reside and they circulate. And a lot of the immune recognition is happening in the lymph nodes. And the idea is to target a lymph node that drains the pancreas. And that's the reason why we're going to go into the groin. And by going into the lymph node that drains the pancreas, we're hoping that the trafficking and all this circulation that is happening, you have this signaling that, again, re-educates the immune system, and you probably dampen down the immune attack towards that particular antigen. So this is a cartoon showing this, where you inject the GAT65 in this particular study. The antigen that is being presented is GAT65, and it makes sense that patients, therefore, to be eligible, need to have the presence of this antibody. The immune system needs to have been activated for you in this particular scenario, come back and try to re-educate and trying to say, do not become active towards GAT65, do not damage the cells. So the GAT65 is injected into the lymph node, depicted here in gray. Then you have these immune cells, these white blood cells that engulf and kind of like suck up the antigen. It's broken down, and then it gets presented to other white cells. And that presentation, in the way that it's done, allows for the immune cells to become those T cells that are the ones, those T cells that are the ones that actually damage. And when we talk about T cells, the audience needs to understand that there is this intricate balance between regulatory T cells, which are the good cells, the one that keeps the immune system at bay, and the autoreactive effector T cells, that are the ones that get activated when you have immune recognition and will destroy the beta cells. So what this tries to do is it tries to decrease those autoreactive T cells to have them deactivate. And you actually trigger the formation of regulatory T cells to modulate the immune response and hopefully decrease the destruction of insulin-producing cells. And the way that this study goes is it allows for ages of 12 to 28. It has to be within 6 months of type 1 diabetes duration to be eligible. Patients get 3 doses a month apart and an injection into the lymph node. And there's a lot of data already in kids that has been very safe with no side effects with the injection. There's a little bit of discomfort, of course, but apart from that, there has been no reaction, no allergy reactions, no problems with this particular therapy. And patients get vitamin D supplementation as well, and they're followed for 24 months. But that's the idea and the logic behind the utilization of this antigen therapy. And moving now into another trial, this is from Core Pharmaceuticals and is a CMP study. It also works with antigens. And the technology here is unique in that the sponsor has created this polymer matrix, this capsule that houses now not only one antigen, not only the GAT65, but 4 different antigens, pancreatic antigens that elicit an immune response. So the idea is that we're not only giving one, we're giving 4 of them to hopefully re-educate the immune system to not have a response against those antigens, which are in the pancreas. So those antigens are housed within these particles, and those particles are then delivered to the patient. But important thing is that we know that the recognition in the immune system occurs if you have a particular gene profile. So therefore, patients need to be tested to see if they have that gene profile, that HLA profile, because if they don't have it, they're not going to be presenting or recognize this antigen presentation. So it's also very targeted, which I think is important, so we can be more selective of a therapy that may be more effective in the patient population that we are enrolling. And again, the mechanism of action or the hope of how this will work is similar to the one with the Diagnose-3 study. You give, as the first to that one, you don't give them in the groin. These are given through an IV. You give all these capsules, they go through an IV, and they go to the liver and the spleen that are actually immune organs as well. And then you have white blood cells there, immune cells that would engulf the capsules. The capsules then get processed inside the white blood cell, and then they get presented to this other type of immune cell, which with the hopes that it will re-educate the immune system, favoring regulatory T cells and deleting those autoreactive effector T cells, and other cells will come inactive completely. So if this were to work, you will be essentially causing tolerance towards those antigens and dampen the immune response. And this is an adaptive design. What it means is that it will change based on what happens with the conduction of the study. Initially, it starts with adults. We want to start initially in adults, and if there is safety, you start going down on the ages, as you can see here. Patients get 3 doses at day 1, day 8, and day 90. And then there's safety monitoring that occurs, make sure that everything is safe, that we can proceed, and different doses are tested. And ultimately, if there's no safety signal, if everything seems to be working okay from a safety perspective, the study may actually be expanded. It has an expansion phase with participants ages 12 to 35 that can be enrolled in the study. But at this point, the study is from ages 12 to 35 with 180 days of type 1 diabetes duration to be eligible, up to 180 days. And now we shift gears from antigen therapy, stem cells, to the Fabulinus trial from Sanofi. And the Fabulinus trial from Sanofi is different in that it uses a drug that is actually working to prevent activation of the T cells. So now what you want to do in this scenario is actually prevent activation and decrease the immune response by giving a drug that blocks this stimulation and this particular pathway that triggers antibody formation, that triggers effector T cell formation, and triggers also inflammatory substances release. So by blocking that pathway with this drug, we want to slow down and deactivate the immune system. And data in laboratory studies show that higher doses are stronger in dampening the immune response. It dampens the activation of those T cells. As you increase the doses, those T cells become less active and less active, and by blocking this particular pathway. There was a lot of interest in this particular drug many years ago in this particular pathway, but the first generation of these agents, unfortunately, was associated with the formation of clots. But the new generation has circumvented that problem and is no longer causing clots. And now we can test this therapy, which has already been shown to be effective in multiple sclerosis. And therefore, there's interest to use it in other autoimmune conditions, such as type 1 diabetes. And another unique aspect of this trial is that as differs to other clinical studies where the treatment may be given over a short period of time, here for this particular study, you continue giving injections of this drug every 2 weeks for up to a year. So you continue to be exposed to the drug because you want to continue blocking that activation of the T cells. So for 1 year, you're staying on the drug, and then you have a long-term safety follow-up in addition to make sure that everything is safe after patients have completed the treatment phase of the study. The duration of the disease is 90 days. They are up to 90 days of duration. And you can see that it starts in patients 16 to 21 years of age, and ultimately goes down to ages 12 to 15 years of age. And there is a different trial from Gegenti Bio, a company called the Polaris studies. And this is unique in that it uses the regulatory T cells of the patients. So as differs to other studies where you're giving these drugs and you're giving stem cells, this one takes advantage of the same T cells of the patient. So what happens in type 1 diabetes, again, we discussed about regulatory T cells and effector T cells. Your regulatory T cells are dysfunctional. They're not working correctly, and you have low numbers. And you have this predominance of the effector T cells. So this balance between the regulatory T cells and the effector T cells is lost. So the idea is to, through a process called plasmapheresis, those cells are extracted from the patient, and they're engineered in the lab in such a way that now those regulatory T cells are healthier, they maintain their T regulatory function, and they survive longer, and they also have this targeting, and they go directly to the pancreas. Because of a modification in the cell, it will hone in into the pancreas. And on top of that, it's been engineered to be able to respond to a pill, an oral medication that patients will take to allow for these regulatory T cells to remain healthy and live longer, because you want them to try to block down the immune responses. So again, it's the patient's own cells, but they are genetically modified in the lab, and they're given back to the patient. So because it's a first-in-human study, the first thing is safety, and they start with only 3 patients with a lower dose of cells. Then this is reviewed with a safety committee. If everything is okay, you go to a higher dose of cells, another 3 patients, and if everything is okay, you open it up to 10 patients, you give the higher dose, and you give that oral medication that I mentioned, which patients will take for a week every 30 days, and that medication allows for those regulatory T cells to be healthy and do not die as quickly and maintain their function. And this includes only adult patients. Again, it's a first-in-human study. We need to first determine the safety in adults, and it's up to 120 days of patients of duration of type 1 diabetes. Now, let me shift gear now to the Safeguard study. The Safeguard study bases itself from the TN19 study that was previously shown by Dr. Blaschke using a drug called ATG, or anti-thymocyte globulin. What that drug does is that it really wipes out your lymphocytes. So you get rid of those cells that are attacking the immune system. So you wipe them down, and then as the numbers of the cells start coming back, you also get some regulatory T cells, and it has shown great efficacy. The problem is that it's made from a rabbit. It's rabbit ATG. And because it's made of a rabbit, you have the risk of reaction and allergic reactions to the medication. And indeed, the vast majority of patients get an allergic reaction known as serum sickness, that you can have fevers, rash, tremors, and some of them need steroids. And you can imagine how cumbersome it is for a patient with type 1 diabetes, particularly recently diagnosed, to go on steroids if they get this serum sickness, right? So what this company did was they humanized it. Now, a similar molecule of thymoglobulin now has been humanized. And because it's humanized, you no longer have that serum sickness. And in addition, it does not deplete significantly the lymphocytes, and it preserves some of the T regulatory cells. So it offers some advantages, some clear advantages over the rabbit thymoglobulin, but we still need to do the study to see whether it will also preserve C-peptide. The hope is that it will do so because the mechanism of action, the way that it works, is almost exactly and quite identical to thymoglobulin, which already has shown efficacy. And it offers these other advantages. But again, this needs to be tested in a clinical trial. And the study here is for adults ages 50 to 40 years of age, diabetes duration of 100 days, and it has two step downs in ages. Based on the response and the safety, the study may allow to open it up to patients ages 12 and up. And if there continues to be safety, it can be opened down to ages 5 and 11. And patients, as a matter of fact, in this trial, we get 2 treatment courses. So the initial treatment course of 2 doses of this agent, and then 6 months later, they get it again, because data suggests with this particular agent that you may be losing the effect by 3 months. And therefore, it seems logical to redose patients to kind of like give them a booster and continue with the benefit by giving a second dose. And the study lasts for it's 1 year of follow-up, of treatment and follow-up. And last but not least, we have the WAVE Type 1D study. And this is unique in that every single patient gets ATG, human though, anti-thymocyte globulin. You may argue, well, why not the other one that is humanized? The other one that is humanized has not been tested yet. We do not know whether it will work or not. Here, every patient is getting a drug that has already shown that it preserves C-peptide up to 2 years from diagnosis. So everybody gets ATG. And on top of that, they get an additional drug. So you have to view it from a perspective of you have this induction, this agent that is given early on, and then you have this maintenance medication to continue having either an additive effect or maintenance of an effect later on. So here patients will get in one group placebo, in another group verapamil that was previously shown today that it did have an effect in children, although the data in a European study with adults did not show benefit. So the jury is still out in terms of how this will pan out. And then adalimumab, which is a similar agent to golimumab. This is a TNF-alpha inhibitor that is a drug that has been used for other autoimmune diseases. And we expect to have the similar benefit than the golimumab study. This is an injectable medication. It's given under the skin. Verapamil is an oral agent, and ATG is given IV 2 doses. But again, every patient gets ATG, so everybody will have benefit from that. And then we will test whether the addition of any of these 2 agents provides even further benefit. And it will go from ages 9 to 21 years of age, and patients can be less than 6 months of duration to be in the study. So this is to give you an overview of all the exciting things that we are currently doing at the DRI. There's really been an explosion in the stage 3 of type 1 diabetes with new agents coming in, targeting different pathways, whether it be from blocking the activation, whether it be from inducing tolerance, really creating the immune system, whether it be with stem cells. All of these things are being tested, increasing the opportunities of our patients to provide hope and options of treatments that, if successful, will have a unique impact by minimizing the loss of C-peptide. And nothing is better than your own insulin production. And with that, I'll stop and open up. And Dr. Blaschke, if you have any other comments, we can then open it up for questions.
Yeah, my only comment is what you just said. I just want to reinforce that preserving the C-peptide means retaining more of your own body's insulin production, which can improve long-term management, reducing your insulin needs and lower your risk of complications based on the studies we have done in the past.
Thank you, gentlemen. That was tremendous. We have quite a number of questions that have come in. We're not going to get to all of them, but I do want to go through these as quickly as possible. And those that we don't address on this call, we will follow up with you independently following the call. So thank you for that. First, there were a number of questioners who raised the issue of allergic reactions to pumps, to CGMs, et cetera. Can you speak at least at a high level about companies that are perhaps more sensitive to that risk of allergic reaction, be it to metals or tapes, et cetera, and what people can do who have a particular allergic sensitivity?
I'll take that, Carlos, if that's okay. So we can talk about, there's two things. One is the skin reactions that occur to adhesives with the CGMs or with infusion sets. And unfortunately, most of those are related to the acrylic in the adhesive. And some patients clearly have much more sensitive skin. And there had been some changes in some of those infusion sets and some of the sensors to try to minimize the allergic reactions. I think it's a little bit better, but some patients still have this. There are great resources. It's actually a website called Panther program, where if you go into there, it provides guidance to patients on these technologies and on this, and for it's actually skin solutions. One of the things that works with many of my patients is that they can use a hydrocolloid that is sprayed, and you can actually buy this. You put it on the skin, and then on top of it, you put the sensor. And the sensor pierces this, so the sensor is attached on the hydrocolloid, this little tape that you put on top of the skin, that minimizes the contact of the adhesive of the sensor to the skin. Another option, patients have also used, in some it works, in others, unfortunately, they still have some skin reactions, is the use of Flonase that you can even actually get over the counter. You know, the nasal spray that it's a nasal corticoid. It's a steroid that you spray it on your skin. By spraying it on the skin, you kind of like create this little surface with the steroid and then put it in the sensor or the infusion set, and that can also minimize. Yes, there are some patients in which I've been successful and that the reactions are less, and sometimes the compromise is that although you minimize the reaction, you still need to remove the sensor earlier to minimize the risk. Sometimes patients find an area of their body that is less reactive to another. So rotating and finding that spot that may be less reactive is also another approach. And one issue is if you have an allergy to the Teflon or to the cannula, and I have seen some patients that had infections, or they get infection, not only a reaction, but infection, and those patients may actually benefit from steel cannulas in their infusion sets, as a matter of fact, instead of going with the Teflon cannulas. But those are some of the things, and it's also on a case-by-case basis, and you need to just try different approaches to try to minimize that.
Thank you. What is the main difference between the prescribed automated insulin delivery systems you presented today and the newer over-the-counter options? And what is the most important thing to consider when choosing what will make one's life easier to manage?
So there was this movement of do-it-yourself systems that became available and within the type 1 diabetes community. There was a lot of frustration that there was not significant advancement in algorithms and automation of insulin delivery. This really pushed, it was amazing. This community of people and engineers created these algorithms and systems, and people that could actually buy initially a Medtronic pump that they could break into, and then introduce the algorithm that was controlled by a phone. The problem, although that I think is unique and patients can benefit from that, the issue right now is that now we have FDA approved systems. If you go on these do-it-yourself systems, many endocrinologists or diabetologists are not aware of it because there's no training. And nobody will be responsible for it. The patient is responsible because you are doing this on yourself. you cannot hold a company liable for it. Whereas if you go through an FDA-approved system, you have years of research going on into this, and you have a company that supports it, and it will be paid by the insurance, right? And providers are likely to be trained in those systems and provide better guidance. I do have some of my patients that are using do-it-yourself systems, but I have the luxury perhaps of becoming familiarized with those systems and having some sense of how to guide them with. But not many people in the community are aware of this. So, and I don't think at this point those systems provide really superiority to what we currently have available. And I will actually tell the community and the audience to really look into all the options of systems that are FDA approved right now and just find the one that fits and suits them better. There's so many options to choose, and all of these physicians will be trained, and you have the backup of a company and is approved by the FDA and will likely be covered by the insurance. And you will get good or even excellent glucose control.
When my son was diagnosed with type 1 at the age of 17, he used insulin pens, and I knew how to check his blood and what to do in an emergency. With these complicated pumps, I don't have a clue what to do if he passed out, drank too much. I know defibrillators are designed to instruct users. Are there functions in any pumps available so a passerby could actually help in an emergency situation?
I think that's a great question. Unfortunately, there are not, but what I want to highlight is that education is key. And what I do tend to see, unfortunately, and I think it happens perhaps too frequently in the community, is that a patient may go on one of these systems without getting adequate and in-depth education. It's not just knowing how the pump operates, it's knowing how to troubleshoot it to exactly avoid scenarios as it's being depicted by the person who just raised this issue. I'm hoping, so I can tell you that the systems are relatively quite effective if the settings are correctly entered. But if the settings are off and the patient is not vigilant also, issues and problems can occur. What I do recommend, and this happens with other conditions that were chronic conditions, is that patients should have a medical alert bracelet so that a passerby may know what to do from the perspective of what are the concerns that can happen. Severe hypoglycemia, passing out because of a low blood sugar. You should always have rescue carbs available, either being glucose tabs or even glucagon available, so that if you have a medical alert bracelet that guides a passerby that you passed out and I need to intervene, and this patient has diabetes, they may think about giving glucose to the patient, depending on the situation, right? But I wish it was different, but unfortunately, the systems do not have a way to alert or indicate to a passerby what to do with the pump. I will actually not want a passerby because they can actually complicate further the problem. So again, it's one of the limitations. Education is key, but the reality is that to get to a patient to pass out on this system is because they probably have not been attentive to the alarms, because the system will be constantly alarming you that something is happening. So, but again, errors and problems can occur.
Carlos, I didn't want to cut you off. If there's anything you wanted to add, please do so.
No, I'm okay.
Okay. Which AID systems are approved for children under the age of 12?
Essentially, all of them. At this point, all of the systems,
All of them.
and some of them go to much even lower, even 2 years of age. So all of these systems are available.
Thank you. Any possibility of a truly non-invasive finger testing someday? What companies should we follow in this regard?
I really hope so. I think there's a lot of work going on. Until I see it, I don't believe it. So, and I cannot pinpoint to any company, but I think that we may get there. It's a little bit complicated once you don't have a direct sample. Companies looking at light waves and so forth to try to measure the analyte. I think it's a complicated endeavor. I'm hoping that the technology advances to really having that. We're not there yet. The best that we currently have is clearly CGM that requires a filament, a sensor inserted under the skin, and which is really unique, right? You only put it either every 15 days or every 10 days. It reduces or significantly minimizes the finger sticks. But again, I look forward to the point when we will get to have a non-invasive blood glucose monitoring. We're not there yet, unfortunately.
Dr. Blaschke, will future stem cell trials address type 1.5 diabetes?
That's a very good question. The problem with stem cells, most of the stem cells that we're doing is in the long-standing diabetes, in the newly diagnosed trials. I just saw that question that it pop up in the chat right now. It also comes to the question that they were asking about the genetic test, the genetic therapy in type 1 diabetes, and Dr. Vidal did a very good job explaining the GentiVio trial that is actually in the GentiVio is engineering T-Rex, so it's actually a gene therapy, kind of a gene therapy, because they engineer regulatory T cells via gene editing. I don't know if David wants to comment a little bit more about that.
Yes, happy to provide. With stem cells in type 1.5, the problem with LADA is that we don't have data. We need much more research in that patient population. That's the issue. We're still just learning about type 1 diabetes and what interventions are working and early on in the disease duration. So as we get older, in type 1 diabetes, the progression of the disease is slower. So measuring the impact of an intervention will take a long period of time. And then you have to have a control group similar to that patient population, which makes it a little bit tricky in terms of the number of patients that you will need, the duration of follow-up. I think we do need more research. I'm hoping that we open up, once we learn more in the space of younger patients and younger adults, to really open the door to trials with older adults and those that develop diabetes after age 45, for instance. But we also, again, we need to learn more about the natural history of how the disease progresses in those patients. And we don't know much. And that's a limiting factor when we try to offer therapies or studies to those patients. I wish I had a better answer, but that's, I think, the reality at this point. Yeah. And in regards to gene therapy, in therapy that is really modifying the genetic profile of a patient, we're not there yet. I am unfamiliar at this point with gene therapy studies specifically for type 1 diabetes. Once they come, I will be interested in reviewing them. As you can imagine, there's a lot of safety issues that will need to be addressed to feel comfortable to using a therapy that modifies the genetic makeup of a patient. So I will need to have enough safety and preclinical data before jumping into a human trial. But again, I'm not aware of that, but I think those sorts of therapies hold great promise and could be curative indeed.
Yeah. And also, I want to add that historically, most of the trials that we have done, one of the exclusion criteria in most of the trials is the LADA population.
And actually, that's a segue to another question that came in about gene therapy specifically, which is, my beta cells have been gone for years. I understand gene therapy for diabetes will soon be entering human trials. Is the DRI involved in any way, and what counsel can you give in that regard?
Yeah, I just want to add that the only close to gene therapy that my understanding that we do at the DRI right now is what I said about the GentiVio, because it's a gene therapy adjacent, so it's more like a gene editing. But we are actually engineering regulatory T cells, T-Rex, via gene editing. That's the only one close by. Maybe other centers that I'm not aware, but these are the only gene edited therapy that we have right now in our clinical core. Yeah.
Very good. We'll get through a couple more and then we'll be closing out. But what is the risk of letting type 1 diabetics use medicine that's intended for diabetes prevention in case there might be any chance of usefulness or benefit?
Guys, you want to take that? Or would you like me to take it? I wanted to check to with Carlos. Would you like to take it, or do you want me to address it? How?
No, you can address it. I can follow up.
So we have to highlight first that we only have one therapy approved at this point for prevention, and it's not even prevention, is to delay the progression of the disease, right? I wish we had, and I could tell you, yes, we have prevention drugs, and probably they work in that stage of the disease. I'm hoping that they may also have an impact once you have diagnosis of type 1 diabetes. But the issue is that we don't have such drugs. And the only one that has really shown efficacy from the perspective of delaying the progression of the disease is teplizumab, which actually, in a well-designed study, showed that in new onset disease, so down the line, right, from prevention to actually new onset and preservation of insulin production, also showed efficacy. And as Dr. Blaschke mentioned, most likely that drug will become available soon so that patients can be eligible to get it and covered by insurance. One word of caution is, however, that with any therapies, we need to keep in mind there are responders and there are non-responders, and we're still learning who will respond and who does not respond. We do not still have the appropriate testing, perhaps, to allow us to discriminate and determine that with high accuracy. But in any event, at least we do have one agent that will be available in both spaces, right, for prevention and in new onset disease.
Thank you. Last question. I'm sorry, go ahead,
No, I just want to follow up also that because we have done many, as you can see, for the studies that I presented and the studies that Dr. Vidal presented that we're recruiting, you can see many of these single agent drugs that we have used. Now we're doing combination therapy. And just want to highlight also what Dr. Vidal said about the different population, about non-responders and responder and not so good responders. It's just that we have to look, we're learning more about the natural history of the disease. Maybe the age group could differ, maybe the HLA typing. There's some people that the antibody levels or which antibody is positive. It can actually be a factor determine the efficacy of these drugs too.
And this last question actually is about combination therapies specifically. We hear a lot about combination therapies as the likely key to unlocking a cure. With many research avenues being pursued in parallel, including several you shared this evening from the DRI, what is your best educated guess as to which therapeutic approach will ultimately solve the mystery?
A very tough question. It's a very tough question. I mean, if you look at type 1 diabetes, there are ways to tackle the disease in different approaches. We can, the immune system is very complicated. We can target different steps in the immune response. And then we have to be very careful which drugs we're tackling and what combination we're using. But if we can have a drug that really promotes beta cell health and slow down the immune response, I think that's, and maybe we can get one that helps for beta cell regeneration in the future. That would be a win situation for in the field. Yeah.
Yeah, and adding on, indeed. So that's the question, right? I think what is the combination therapy that is the holy grail here that will get us to really preserve the peptide? Remember something very important. We're talking about stage 1 type 1 diabetes and these trials, and then my personal view is that at that point you're not curing the disease. You're just saving you're trying to save as much as you have left, right? And but that's where we're going to start, right? Because you have a better justification to give a treatment once you have the disease than to start when you don't have the disease, at least to try it out first, where you can determine the safety and the efficacy, and then you start moving backwards, and then you start testing it early on. But as Blaschke mentioned, we need to target different aspects, something that will regulatory T cells, that enhances the regulatory T cells and shift that balance of effector versus regulatory T cells, something that blocks the activation of the T cells, an anti-inflammatory agent that reduces the inflammation. And a beta health agent, this has been something that provides the better responsiveness of the beta cell, so that you make the cell healthy and actually stronger to resist immune attack. So this has been advocated by Dr. Schuyler here many years ago, and I share completely his view. So you need a multi-pronged approach, but it adds to the complexity once you add more agents. We cannot tackle this disease with 1 or 2 drugs. I don't think that's going to be the way to do this. You need to tackle it in different pathways. You just need to find the right combination. And we're just getting started. We're just now doing combination of 2 drugs. And we'll have to see whether that works out or not. But if that is effective and it shows a better response than other trials, it will open up then the landscape to multi-therapy in patients with new onset type 1 diabetes. And that may hold the key to better preservation and then going back in early stages and hopefully prevent the disease more effectively.
Yeah.
Thank you.
Also, I just want to follow up with something just want to follow up something that I'm very excited what's happening in the field right now. Sometimes when we look at the medications we're using right now, one of the cases, the ATG, let's say the ATG now, the humanized, works out how it's supposed to work. We can prove the hypothesis. It will bring, for example, that maybe in the future we can redose with different medications. If we can achieve probably chronic, if we look at the studies that I presented, most of them, they work really well, but then when they stop the drug, it start to shift again. The immune system comes back and we start losing C-peptide. But if we can achieve that part in the sense that we can do chronic, safely I don't want to say immunosuppression, but if we can do that in a safe and chronically matter, I think we can. It's another win battle in the type 1 diabetes.
With that, I will say thank you to both of you for a really wonderful and insightful conversation. And I hope that everybody participating got a lot out of it, as much as I did. I would encourage you all, if any questions weren't answered, we have those recorded that you've already submitted. If you think of any additional questions over the course of time, please don't hesitate to send me an email with them. It's mmyers, MMYERS, @drif.org, and we will speak with our scientists and get responses to you as quickly as possible. And lastly, the recording of this presentation will be available on our website at diabetesresearch.org by the end of the weekend. Thank you all for your participation. Thank you, gentlemen, for your wonderful work and continued success. Thank you, everybody. Have a good evening.
Good evening. Bye-bye.